Hello? Hello there. Okay, I don't know whether Zohir, could you just tell me if people actually can hear me, because I obviously don't hear anything at all. Just put a yes or no, please. That'd be really helpful. So oh, good. You can hear me. That's fine. So my name is Professor Stephen Porter. I'm the Professor of Oral Medicine at the UCL Eastman Dental Institute. I'm also the actually Director of the Institute, and I'm an honorary consultant in oral medicine here at UCLHT in central London. And I've been managing people with scleroderma for about 30 years. And I have a close relationship, particularly with the group up in the Royal Free Hospital with Professor Chris Denton, and prior to that, Professor Black. And I'm conscious that people with scleroderma have many concerns with regard to the mouth. And what I planned to do this morning was just to answer your questions, if you had any regarding this. I am conscious that this is a very difficult time for people with scleroderma and indeed their families because of the impact of COVID-19 and the fact that getting routine dental care has really largely become very difficult, even with regard to dental pain. Now, I'm aware that some of you may have questions, and perhaps questions will emerge from this morning. And what I thought I would do is that to get things started, I would do some questions which have already been sent by SRUK. I also, just to make you aware, I'm not the most IT person in the world. So if there's any issues with regard to that, Zohir from SRUK will be able to sort me out if that's the situation. So if I consider one of the questions that was sent in ahead of this, and this was from a lady called Anita. I don't know where Anita's from, and I don't know if Anita herself has scleroderma. But she was saying that her dentist was not familiar with scleroderma or indeed Raynaud's, and was there any general information that she could give to the dentist on her next visit so that he could understand scleroderma and what to look out for. And certainly there is, because I think SRUK have an information sheet regarding oral and dental aspects of scleroderma. And the initial version of that I think I wrote many years ago, and has since been adapted, and it really covers all the different aspects of scleroderma. Just to emphasize what they are, some people, depending upon the type of scleroderma, then have facial tightness, and the tightness is around the mouth. And as a consequence, the mouth won't open very wide, and it makes it very difficult to speak and to get large things in the mouth or food sometimes. And from a dental perspective, it means it's difficult to clean the mouth. And what's required in those situations is a small-headed toothbrush. Electric toothbrushes have small heads. The problem, of course, is that electric toothbrushes are quite heavy, and if the person has got difficulty with the movement of the arms, then they can be difficult to use. The electric toothbrushes have the advantage that they've got quite a big handle, and as a result, it's quite easy to hold on to them. So there is the good points and the bad points regarding electric toothbrushes. It doesn't really matter what way you clean your teeth, as long as the debris gets removed, and secondly, that you don't damage your mouth. But there's no evidence that people with scleroderma who keep good oral hygiene actually do damage the mouth. So in answer to Anita's thing, there is documentation available, and I think it's on the websites to consider that. Now, a lady, Alexandra, again, I don't quite know where, she's mentioned that she has small lips and her dentist is unable to use a mold to do replacement teeth. And what she's meaning is to take an impression, where the dentist uses a little plastic tray that goes inside the mouth with this goo stuff to take an impression of the mouth, so they can make bridges, or they can make crowns, or they can make dentures. And in some people with scleroderma, the mouth opening can be remarkably restricted. The way to get around this is that the impression can be taken in different parts. To say, instead of using a big tray thing to go inside the mouth, instead 2 smaller halves are used. And then what happens is the dentist and the technical staff then merge them together to do that. However, I will precede this by saying that I am not a restorative dentist. I don't do that kind of work, but I know dentists that do. Not all dentists, let's face it, will be good or able to do that, and it does require a good dentist to do that. Many people with scleroderma will be able to be seen by what's called the community dental service, who are very able and very talented in being able to manage these complex issues with regard to scleroderma and other areas. So I'm hoping that that answers Alexandra's problem. It is an uncommon situation, but it is a known situation, one that the dentist will have some knowledge of. Remember also, the dentist can seek help from others. They can just ask colleagues, or they can ask various specialist societies to give them advice regarding that. And another option is that the dentist, the general dental practitioner, can refer you to a specialist for advice as regards how are they going to be able to provide the dental care which you may require. So hopefully that answers that issue with Alexandra, and if it doesn't, Alexandra, email us back and tell me. Okay, so there's a lady called Michelle who'd sent an email to SRUK, presumably Ollie, and said that their teeth were awful. And she goes to the dentist every 6 months to get them cleaned, and it makes no difference. That she's got holes that are now going below the gum line, and the dentist isn't sure why, and the teeth are beginning to crumble. And of course, the more the teeth crumble, the greater the risk of them needing to be removed, and then the greater the more complicated it becomes to make dentures or even to do implants, which are very expensive. So there is no evidence that people with scleroderma have inherently weak teeth. Okay, that's important to understand, that the teeth which we have by adulthood, they don't change as regards their content. They can be attacked by dental plaque because the acid destroys things. But the teeth themselves in people with scleroderma are inherently normal. But some people with scleroderma do seem to have this problem that the teeth crumble. And this is in all probability caused by them having a feature of scleroderma where the salivary glands are being affected. And some people with scleroderma have this, and it's called Sjogren syndrome. And this is where you get an attack taking place in the salivary glands and also the glands of the eyes, the tear glands, the lacrimal glands. And the salivary glands start to stop working. And why we have saliva is it's there to lubricate the mouth, to make it easy to speak and to swallow. And secondly, it protects the mouth from the effects of dental plaque. It makes it more difficult for plaque to stick to teeth, and also dilutes the effect of any acids that the plaque generates. And so people with scleroderma, if they have a loss of salivary gland function, they are more predisposed to dental decay, and the teeth will start to crumble a bit. But there are three principles that stop dental decay. The first is a good diet, a diet which doesn't have lots of sticky, sugary things in it, because that plaque loves that. It makes more plaque and it makes more acid, which destroys the teeth. The second thing is that some way of cleaning the teeth is important, because if the teeth are clean, there's no plaque, and therefore the teeth can't crumble. And the third thing is to have fluorides, because fluorides in toothpaste harden up the surface of the tooth and stop them getting decayed. So to prevent teeth crumbling in people with Sjogren syndrome, there needs to be a diet which doesn't have lots of sweet things or sticky things or frequent things. You can have it obviously at meal times. The second thing is to have a way of cleaning the teeth. And the third thing is to use a toothpaste which contains fluoride. The fluoride toothpaste which are available across the counter contain 1,400 parts per million. But there's also toothpaste that contain double that, which are again you can buy across the counter. And there's a third group of toothpaste which contain 5,000 parts per million fluoride. And these can be prescribed by your dentist or by your doctor or by any specialist group, a specialist clinician. And that really does harden up the teeth. The problem is when the teeth start to crumble, what can be done? Is there anything different for people with scleroderma as opposed to those not? And there isn't really. The key thing is to hold on to the teeth as best possible. Implants used to be considered to be inappropriate for people with scleroderma because they were on immune suppressants. There is no evidence that that is a problem. Secondly, implants can be placed in people with scleroderma even when the mouth is small, because the surgeons can you can get around that issue quite easily. Implants have the advantage that they can support a denture and it won't drop out, or they can support bridges and crowns, so everything looks functionally good and aesthetically all right. But implants are expensive. Within the NHS, it is possible under certain circumstances to get implants, but a very good case has to be made for it. And we've certainly made cases for patients as regards implants to have them done under the NHS, and it's not been a problem from that point of view. But to come back to the crumbling issue, the crumbling issue in all probability is caused by dryness of the mouth. And regardless of whether someone is a dry mouth or not, if they have scleroderma, the three principal things are to not have too many sugars. Secondly, to have some way of cleaning the teeth. And thirdly, to use fluorides. And that does make a difference, without a doubt. Alexandra says my answer was worked, but that's good. So Emma, she sent a question about a thing that she's got temporal mandibular disorder, and she wondered if it's linked to Raynaud's. And she says that she asked her consultant, whoever he or she was a he actually, and he just laughed at me. Well, that wasn't very nice, Emma. So let me tell you about this. Temporal mandibular disorder is a pain which occurs on the sides of the mouth. If you look on my screen, I've got the light off so you can see me. I'm not very attractive, by the way. And it's here. And it's pain that goes from the side of the jaws and sometimes goes up to the temple. And it sometimes goes under here. And it's like a cramp-like pain. And the patients who get it sometimes find it difficult to open their mouths. And very occasionally they get locking of the mouth, but that's exquisitely rare. And this is common, but it's common in people who don't have scleroderma, and it's not that common in patients with scleroderma, and it's got no link at all with Raynaud's phenomenon. What's actually happening is that you get pain in the muscles. It's nothing to do with the joints. The temporomandibular joint is this joint here, the jaw joint. And the reason why the people get the pain is that they're clenching or they're grinding their teeth and they don't even know they're doing it, okay? And sometimes patients awaken to the pain in the morning because they're clenching in the night. That's called bruxism. And people are clenching or grinding because they're upset with something conscious or something unconscious that one doesn't often know. And the way in which this is managed is, well, if you could identify the cause, that would be great. But sometimes it's very difficult to identify the thing that's making people upset, or indeed for people to realize that they possibly have an element of upset. And it's even more difficult sometimes to remove that upset if it's a worry about health, about money, about relationships, about elderly parents, about children, whatever else. But the good news about this thing is usually, in most cases, short-term, few weeks, few months, and it does respond to simple painkillers. Splints have been used in the past, and splints, the evidence is they don't work. They actually probably do work for the majority of people. And a splint just consists of a little gum shield that the patients wear. The problem, of course, with people with scleroderma is if they've got difficulty opening in the mouth, then you can't take the impression. But as I said, you can get around that issue by using a denture that's split into two. So temporomandibular disorder is common. It's more likely in young people than older people. It's suggested to be more common in women than men. It has no link with scleroderma, nor has it any link at all with Raynaud's disease. It's caused by the distress of life, is usually short-term, and painkillers or splints work. Some people say that if you put something warm in their joints or put something cold, it works. There's no strong evidence it works, but every individual is different. And if you find a trick that works for you and doesn't cause harm, then continue to do so. So I hope that answers the question of Emma regarding this. And someone else asked about TMD, whether it sends little shocks into the teeth. Yeah, some people with temporomandibular disorder can get little electric shock-like discomforts in there. There is a rare thing called trigeminal neuralgia, which is different, which doesn't have a strong link to scleroderma. And this is really terrible electric shock-like pain occurring in the face. And that's completely different. But little electric shock-like pains in the muscles, this area here, is not uncommon with temporomandibular disorder. So hopefully that answers the question of that. Now, someone's asked about receding gums. I think there's a lady called Tracy, and there's someone else has asked also about this. And I'll combine those two. Okay, so receding gums. This is where the gums become more, they pull away from the teeth, so you see more of the root. And the old name for this was long in the tooth. Now, receding gums really means that there's inflammation in the gum tissue. And you've got the gum, we have the gum tissue to hold the teeth into the bone. And if the gum tissue goes away, then first of all, it exposes a little bit of the root. So the people start getting pain with cold things, and that's called dentine hypersensitivity. Then when it starts to really recede, that means the underlying bone holding the teeth in is disappearing. Then the teeth start to become a bit loose. And you've also got the risk that food gets trapped between the teeth. There is no strong evidence that people with scleroderma have an increased risk of this problem. Its technical name is periodontitis. However, I would think that because periodontitis is caused by dental plaque, and some people with scleroderma have difficulty in being able to remove all the dental plaque, that they will have some degree of increased risk of periodontitis. So the way in which this can be managed is that you need, first of all, it's prevention, it's tooth cleaning. Now, the people who are specialists in periodontology say, well, you know, you need to clean in between the teeth as well because toothbrushes don't reach it. But I'm a realist, And if you have someone who's got scleroderma or severe Raynaud's and it's affecting their hands, their manual dexterity will be reduced, and therefore cleaning between the teeth can be difficult. The best way to clean between the teeth is whatever suits you, be it floss, be it with little floss holder things, be it with brushes, which can be short handle brushes or long handle brushes. Anything goes, frankly, as long as it doesn't cause trauma to your tissues and doesn't cause you upset. If someone has got gum recession, we'll call it, or periodontitis, then the way it's treated is, first of all, to find a way to stop it getting any worse, because it can't be reversed. So that's just tooth cleaning. Secondly, they need to be seen by a hygienist or a specialist in gum disease, periodontology, to make sure that they scrape off any hard tissue called calculus or tartar, because that it itself doesn't really cause the disease, but it makes it easier for plaque to stick, and therefore that means it's going to cause the advancement of the gum recession. Sometimes the specialists in periodontology do some surgery to change the shape of the gum to make it easier to clean between the teeth. That's obviously done by specialists, and good specialists exist for gum disease in all the major dental hospitals around the country. There's one in all the major cities, and there's 3 in London. So gum recession or gums disappearing or shrinking isn't a major feature of scleroderma, but as we age, we have an increased risk of it in any case. And prevention, good tooth cleaning, is probably the best way to help with regard to that. And I hope that answers the question that I think Kim sent. I don't know where Kim is from, but I hope that answers her question. His or her question, I'm sorry. So Lally has asked a question about that her mother has Crest syndrome, which is an old term, of course, but anyway, and she had a lower molar that's had to be extracted because of resorption, and she wants to know about increased risk of resorption in people with scleroderma. So resorption, this means that the roots of the teeth are disappearing, and it can arise in scleroderma, but it is remarkably rare. Let me give you some information about what happens to the jaws in scleroderma. In people who've got a very tight face, what happens is a consequence of the pressure of the external tightness, together sometimes with a change in the way the muscles pull the jaw bones. The jaw bones change, so you lose bits of bone. You don't notice it, it just slowly disappears. For example, down here in the border of the lower jaw, which is called the mandible, it's the most common place, and very occasionally up here on the cheekbone, but that's very, very unusual. And what happens is with that resorption, that disappearance of bone, it can come high enough to affect the roots of the lower teeth, but is exquisitely rare. I'm aware of only about 2 or 3 patients ever reported with regard to that, and one of them was a patient whom I wrote up. But resorption of the roots can occur for other reasons, because do bear in mind that for the people with scleroderma, the problems they get in the mouth may be specific to scleroderma, or they may be completely unrelated and just reflecting common dental problems. And something that can happen is that if people have teeth that have died off, and what that means is they've had a hole in a tooth, dental decay, and it's gone down to the pulp where the nerve and blood vessels are. And when that dies off, if it's killed off, there's a risk that you get some infection occurring around the end of the root. That can present as an abscess, pain, or it can just slowly cause some mild inflammation, which causes the root to resorb a little bit, or even a cyst to form. Now, people who have got resorption of roots, it's not the end of the world, because they can be seen by a specialist in roots. They're called endodontists, and they can decide what to do. And often people can have some degree of resorption of the the end of the roots, and it doesn't give rise to painful symptoms. It doesn't affect the mobility of the tooth, and they don't lose the tooth. So it depends upon each individual. But there is no strong evidence. Well, there is evidence that Scleroderma can cause resorption, but it's exquisitely rare, and it doesn't seem to show a link at all with any specific type of Scleroderma. Someone has asked, excuse me, I'm trying to do this as fast as I can. And there's a nice lady, Katarzyna, she's asked that is it possible her teeth are getting worse because she's taken Cellcept as a suspension? I don't know if Cellcept, which is mycophenolate mofetil, if the suspension comes in sugar. I don't think it does, in truth. And that would be the only reason, excuse me, having a drink, why Cellcept suspension could worsen dental decay. So I don't think that there's a link with regard to that. Then she's asked about swallowing. Now, clearly people with Scleroderma, swallowing abnormalities arise from either problems in the mouth and upper throat, or they lie within the gullet, the esophagus. And I am not a specialist in esophageal Scleroderma. But if people have got difficulty swallowing and it's coming from the mouth, in all probability it is due not so much to the mouth being small or the tongue being abnormal, but it's just due to the dryness. And ways to increase the oral to lessen the oral dryness is the only way you can get around those issues. I should say that the treatment of oral dryness in people with Scleroderma is actually not particularly good. There are no really good trials to show that particular agents work. And in practice, we have a number of saliva substitutes that we can use and gels, but they're not, they work for some people, but not others. Some patients say that certain products are better than others. Everybody is remarkably different as regards that. And it is a remarkable challenge. There's a drug called pilocarpine that can be used to make the salivary glands do more work, but that's not necessarily appropriate for people with lung disease and Scleroderma. But to come back to the question about Cellcept, there's no link with causing tooth decay. And to answer the question about swallowing in Scleroderma from a mouth perspective is usually oral dryness. Now, there have been a small number of reports of people with Scleroderma getting Raynaud of the tongue. That's exquisitely unusual. And there are a small number of reports where the tongue gets smaller in Scleroderma. And the unfortunate name that was coined for that was chicken tongue. I've never had a patient with that. I think it's a remarkably rare phenomenon. And while, you know, one shouldn't just talk about one's own experience, bear in mind that for those of you who know that they're all free, and ourselves have more people with Scleroderma of the mouth than anywhere else in the UK. And therefore, if we're not seeing it, the likelihood of it existing or being common would seem to be remote. One thing that, so Lorraine has asked about secondary Sjogren's and Scleroderma. And certainly, as I said at the beginning, if someone has got Sjogren syndrome, then it will increase the risk of them getting tooth decay, and it probably will increase, there's no strong evidence of it increasing the risk of gum recession or periodontitis. So good oral hygiene is central for that. Now, one fact which I haven't covered about Sjogren syndrome is that it increases the risk of a tumour of the salivary glands called non-Hodgkin's lymphoma. And in people who this, I don't know if there's an estimate with regard to people with Sjogren's and Scleroderma. The people that have Sjogren's alone, which is involvement of the salivary glands and the tear glands, the lacrimal glands, they've got a 1 in 20 or 4.8% chance of getting a tumour in one of the salivary glands. Now, the good news is that the survival rate for that tumour is 95% plus. So the key thing is that if you develop a swelling in a salivary gland, one of the glands below the ear or coming forward under the chin, and it lasts more than 2 weeks, even if it's painless, then someone needs to have a look just to see if that's the start of a tumour, which can be easily solved. The other thing to say about the salivary glands and swellings, by the way, is that if you develop a swelling in a salivary gland, which is painful, and you're known to have salivary gland dysfunction or loss of function, then the likelihood it's an infection, and that needs to be treated just with antibiotics quickly, given by your doctor or dentist. And it's just very simple antibiotics that are used, and that solves that particular problem. People with Scleroderma, Sjogren syndrome, it will increase the risk of problems with the mouth. And the other thing that I'll cover in this thing is that if someone's got Sjogren syndrome, they don't have saliva, and they wear dentures, then the dentures don't stick in the mouth as easily as normal, particularly the upper denture. And that's because you need a thin film of saliva is needed to hold the upper denture in place to create a suction. And if there's no saliva, then that suction is lost. And therefore the denture jumps up and down, which means that the patient has got difficulty eating. They have they lose their confidence socially because they think, oh my, when I speak, my denture might drop down, which is clearly distressing to them. And thirdly, with the denture moving around all the time, they may get mouth ulcers. And the way in which this can be solved, well, is first of all, the denture needs to be good fitting. The denture needs to be reviewed by a dentist every so often to make sure that it is good fitting. Sometimes putting false saliva on the undersurface of the denture helps because it creates the artificial seal. And denture sealants work. There's no reason why those can't be used. And lastly, if someone can get implants, then that's good because they can have these, we'll use simplistically, screws put into the bone, and the denture just clips on and it stays up. So that was the other aspect of dryness of the mouth that I didn't cover as regards that. Kim has asked about, she sees a hygienist every 3 months, but she's missed one due to the present situation. I don't know, was there more of a thing about this one? And that's not the end of the world. You know, the likelihood is that, that if she's being seen regularly, the likelihood of progression of disease, be it tooth decay or gum disease, will be small. The key thing is that is just to try and clean the teeth as best possible, to use fluorides, and to have a sensible diet. Well, just on that, there used to be what it is that sugars, plaque likes because plaque grows with sugar. Secondly, plaque uses sugar to make acids, and the acids dissolve the teeth. And there's the suggestion that if you want to try and minimize the risk of tooth decay or help, you have your meals in reverse. But what you do is you have the sweet bit first, then you have the main course, and then you finish it off with nuts and cheese, because that really keeps the acidity of the mouth down. I, however, am a realist. That's not the way we behave normally. And so I wouldn't advise that. It just seems a kind of pointless exercise to do. Let's see what else we've got. Let me just check. No, let me see. Excuse me. Right, so there seem to be no more questions just now. Let me just check. So I just want to go through some other things. Oh yes, someone's asked about lichen planus. All right, so people with scleroderma can get a number of other things within the mouth which are not directly due to the scleroderma. One of the things that can sometimes arise is this thing called lichen planus. And these are white patches which occur inside the mouth, usually inside of the cheeks, sometimes in the tongue. And they sometimes become red, which means they're thinning out, and they become painful. or they form ulcers. It's not got a strong link to scleroderma in truth, but lichen planus is quite common. It perhaps affects 1% of people. It's more likely in middle to late age people, and it's more likely in women than men. And therefore, you could have someone that's got scleroderma and just completely unrelated, they've got this common problem coming in as well. And lichen planus, you can treat it, usually it's of unknown cause. It is an attack of the immune system, but it's wholly different to the attack that arises in people in scleroderma. And the way in which you manage it is if the patient's just got white bits and that are painless, we do nothing. If they get areas of soreness, be it redness or ulcers, then we give them topical steroid things, creams or mouthwashes, and that calms it down. The bad news is that once someone's got lichen planus of the mouth, they have it for the rest of their life. The good news is the majority of people have painless forms of it and don't require any treatment. 10 to 30% of people who have got lichen planus of the mouth will have it elsewhere. And the common places are itchy little purple patches on the inside of the wrists or the outside of the lower legs. And in females, sometimes there's genital discomfort because it involves that site as well. Lichen planus increases the risk of mouth cancer a bit to 1 in 100 instead of being very low. And in people with scleroderma, the scleroderma itself seems to also increase the risk of mouth cancer. The precise risk is unclear, but it does seem to be 1.75% times greater than people without scleroderma. And so people with scleroderma, with or without lichen planus, have this increased risk of mouth cancer. It is a small risk, but it's there. And the reason for that risk is not clear. Is it the immune suppressants that some people take? No strong evidence. Or is it that the lining of the mouth is thinned out, and that means anything that can cause cancer can just get in more easily to cause a bit of havoc? And no one's very sure. So what should people do? Well, the simple thing is that if someone gets a change in the lining of the mouth that lasts more than 2 weeks, someone should have a look. And that change might be an ulcer, it might be a bump, it might be just something's not quite right, but it's localized, and it's not due to just a sharp tooth or something rubbing against the inside of the mouth. This 2-week rule, if you think something's wrong, then you get someone to have a look, a dentist or the doctor, whatever else. And so therefore the 2-week rule for looking out for cancer of the mouth or the salivary glands is a good one to think of. Something different that can't be explained, lasting more than 2 weeks, is the rule to think of. Someone's asked about toothpaste, Liz, and recommend a good toothpaste without mint. So, problem with toothpaste are wonderful, but most of the time they are designed to remove plaque from the teeth. They're designed to protect the tooth from tooth decay by having fluoride. They contain agents which make it more difficult for the bugs that cause gingivitis to grow. And they also improve breath smell and taste of the mouth. But they have their downsides. And one of the downsides is that they contain flavorants, which sometimes patients don't like. They irritate the mouth in some way because they sting, for example, mint preparations. And there's a toothpaste around called Oranurse, O-R-A, then nurse, which is completely bland. It doesn't contain any flavorants at all. And it's really good because it contains fluoride and it will remove the plaque from the teeth and it will protect the tooth surface. The disadvantage of Oranurse, however, is really boring to use because when you use toothpaste, they usually contain a detergent in it called sodium lauryl sulfate, which creates a kind of bubbly effect in the mouth, which makes it easier to clean the teeth. And that's missing with Oranurse. So it seems a bit psychologically strange to use, but Oranurse is really good because it contains no flavorants. If you don't like mint, then children's toothpaste can be used. The children's toothpaste might contain a lower level of fluoride than adult ones. I can't remember precisely, but that can easily be supplemented by fluoride mouthwash of some kind. Oranus, and I declare I have no links with that company, but I know it's available. It's available in Boots, if I remember. It might be available in, what's the other one called? I've forgotten. Superdrug. And I certainly know it's available online from Amazon. Although I think you've got to buy blocks of about 6 tubes or 12 tubes. It's really good toothpaste. And it's also a good toothpaste to use in children, young children or grandchildren. If they don't want to brush their teeth, it's a good way of going about it. So I would consider using that one. Right, so Rita's asked about implants. So I've obviously created confusion about what they're used for. Implants are a piece of titanium. They're a screw, you might say, and you drill them into bone. And then on top of that, you can put one of 3 things, Rita. First of all, you could just put a crown, so you could replace a single tooth. The second thing you could do is you could have 2 of them, and you can then make a bridge between them, so you're able to place perhaps 3 teeth. Or if someone has no teeth, then the screws go in, and they have a little ball on the top, or a bar, and the denture just clicks on top of it. So implants are just a way of getting something secure in the bone, and you can put a tooth on it, a crown, you can put several teeth on it, a bridge, or you can put a denture on it, click on and off. The world of implants is tricky, and if you were ever going to consider implants, you're well advised to seek good advice from people that will tell you whether this particular practice or whatever is good at implants or not. What's their track record in them? Because implants are remarkably expensive. The actual pieces of titanium are themselves expensive, and the pieces of kit that the dental practice have to use to put these things in are again very expensive, so that adds to the cost. But it's a significant investment for your health and for your purse, and it really is important that you get the best from that. The problem about implants is sometimes there's a risk they can be put in the wrong place, and so before you have an implant placed, you often have scans done called cone beam CT, computed tomography, which lets the dentist see exactly what your anatomy is. Because in the lower jaw, running in the bone, you have a blood vessel and a nerve, and you don't want that to be pranged. And in your upper jaw, you have the roof of the mouth is in close contact with the sinus, the maxillary sinus. So you don't want an implant to be put in with punctures through the sinus. There are ways around all these things, so you need to be assessed very, very carefully. And the second problem with implants is that if the implant isn't kept clean, then there's a risk that the implant will fail, because you start getting plaque accumulating around the implant, and it causes inflammation around the implant, which means that the bone around the implant starts to erode away, and the implant starts to move. It's called, and the disorder that causes that is called peri-implantitis. But I hope I've answered Rita's question regarding the issue of what implants are for. Durafat toothpaste, Lisa's asked, is really good. Durafat toothpaste is called is the 5,000 parts per million one. There is a 2,800 one, Lisa, as well, if I recall. It is really good. I would agree that that's a good way to go. So Anne's asked about shielding. Okay, this is a really tricky one, isn't it? You're being shielded, and therefore even to get a domiciliary visit may be complex. If the shielding, so if you're having pain just now, then I'm afraid the dentist or the urgent dental centres will probably just prescribe you analgesics and antibiotics, but it depends on what the pain is like if you're having pain. If the pain is with hot and cold things, then analgesics are the only thing to use. If the pain is with biting down, clenching, then that suggests that there's an abscess, and that's when antibiotics are required as such. If you've lost a crown or you've got a hole in a tooth that you can reach, then there's a stuff you should get someone to buy in the chemist called Toothy Pegs, Toofy pegs. And that consists of this glue stuff. It's a cement, a polycarboxylate cement, which can allow you to cement the crown back on again. And it also contains funny stuff, which is like a filling material, which can go over holes. And it sticks not badly, but not brilliantly so. The problem, of course, is if you have got Raynaud's phenomenon, if you have got poor manual dexterity because of scleroderma, you can't do that yourself, or it's highly unlikely to be able to do it. And also to see your teeth in the mirror is virtually impossible. So I'm afraid you will have to get someone who perhaps is helping to shield you to do that. But there is, otherwise there's no way around that apart from until the shielding ends. The other thing is that you should contact an urgent dental centre. They should provide advice, and they can make preparations if possible for some form of domiciliary visit for you. Although I realise that domiciliary visits in the present age of COVID are remarkably challenging to get and to undertake for a number of reasons. Someone's spell the name of the toothpaste again. Helen asks. Ora Nurse, O-R-A, and then Nurse, N-U-R-S-E. Okay, Helen, it may be also the way I pronounce words because I'm Scottish. I'm not English. And I know that my accent sometimes people find quite tricky. Sheila has said that she's got no problem with decay saliva. Her teeth feel sticky and food sticks. Glandocene hasn't had an effect. My mouth does not feel dry. Oh my goodness, that's a strange one. Sorry, I didn't mean that rudely, Sheila. Your teeth feel sticky and food sticks, and yet you don't feel your mouth dry. Okay, right. So it's an unusual one, right? So I'll tell you why it's unusual. Go back the way. The sensation of dryness of the mouth is really common and doesn't have a strong correlation with people having lack of saliva and poor salivary function. And so for example, I see many people who complain of a dry mouth, and I find they don't have scleroderma, they don't have Sjogren syndrome, and the mouths are entirely normal. Okay, and so to have a situation where the mouth doesn't feel dry but things are sticking is a little bit strange. Some people, as their salivary glands slow down, if they start to stop working, they can get very sticky, adherent saliva, and what the people often complain of is that when they take a fork out the mouth, excuse me, saliva comes out in a bit as a stringy way. And I don't know if that's the case with you, Sheila. The mouth does not feel dry. So what I would suggest you try, if we need to give you something which is just going to somehow lubricate the mouth in some way to make the teeth, make it easier. Right. So what I reckon is two things, and this is where these kind of things are quite tricky. First of all, get a mouthwash called Dental pH, or DENTYL. This is oily, and it's actually used for gum disease and for bad breath. But it's quite good because it's oily, and that kind of kicks around the mouth after the patient use it, and that might just be enough to actually make your teeth feel less sticky. I would give that a whirl and see where that one goes. But that one's a bit unusual as regards to that. One more thing about oral dryness, forgot to say. The most common reason for people having a genuinely dry mouth is medicines, by the way. And the drugs, the medicines that most commonly do that are the antidepressants, particularly the tricyclic antidepressants like amitriptyline, nortriptyline. The fluoxetine, the serotonin reuptake inhibitors, SSRIs, such as fluoxetine, trade name Prozac, can also do it, but not as much. And so some opioids, if people are on that, tramadol, etc., also dry the mouth up really badly. If you are receiving such medicines, then you will often find your mouths are dry. And the way in which you manage that is the same as Sjogren's. You want to protect yourself from getting tooth decay, protect yourself from getting gum disease, use salvia substitutes, although they don't work particularly well, and importantly, just have water with you all the time. It sounds a real, very similar, basic thing to do, but I'm afraid sips of water in a little bottle is often very helpful with regard to that. Okay. Let's see, Oranus is, there's lots of chit chat about Oranus. Okay, the other thing just to say is that some people with scleroderma, they run into an issue where if they've got oral dryness and they've got tightness of the lips get stuck to the teeth. So when they smile, they hear a joke or something, or they see something nice. When they stop smiling, the lip gets stuck. And the way to get around this, or a way to get around this, is to use some form of lubricating gel on the teeth. There are at least two available. One's called, the trade names are Biotine, and the other one's called BioExtra. But a simple thing, and you may laugh, is to use KY jelly, the lubricating jelly used for other parts of the body. And that works really well. Or the other thing to do is to get a salvia substitute and just spray it up on the lips every so often. And that does seem to lessen this distressing situation when the lip gets stuck on the teeth, anything like that. Okay. Let me see. I think anything else? I think I've covered most of the things that people have asked. I'm just doing a quick check. So let me summarize a little bit. People with scleroderma have got a number of oral and facial problems which are can be remarkably distressing to them and challenging for us as clinicians to manage. And in those situations, then you need to be under the care of specialists. One of the things I didn't cover was the fibrosis inside the mouth. And the evidence is that this can be managed by the injections of the fat-derived stem cells. And there's a really good paper about that, which you're probably aware of, that Professor Denton and Professor Butler did from the Royal Free Hospital. It's a really good paper from that point of view. Good oral hygiene is cardinal to this. Your salivary glands in the mouth. If you get something where that persists, like a pain, an ulcer, or a swelling, and it persists more than 2 weeks, someone needs to have a look at it, okay? Not many general dental practitioners will know about scleroderma because it is uncommon, but they can get advice from the likes of me, etc., regarding that. The mouth part of scleroderma does impact greatly on the quality of life of people. So you can have people with scleroderma where in fact that while they may have other systems being affected, it's the mouth that actually bothers them most. And there's some studies to demonstrate that, including one that we've got about to come out. And it bothers them most because we use our mouths for so much, for eating, for communication, for socializing, for enjoying life. And if something goes wrong, we get embarrassed, we get upset, etc. So the mouth is very important. And my role as a clinician is to ensure that you get the care you require to identify disease which is worrisome and we get it solved. And you as patients or as carers have a role as well, just to make sure that you keep your mouths as clean as possible, because the majority of people with scleroderma, the dominant problems they will get will just be plaque related, plaque induced, and that all boils down to a good diet, a good way of cleaning the teeth, regardless of what way it is, as long as it doesn't cause harm, and using fluorides of some kind. And I think they're the main things from that point of view. So I hope this morning has been helpful to you. I actually, I find it quite lonely here because I can't see you, I can't hear you at all. I just see these messages that come in, etc. But if you have any comments about the effectiveness of this, or me, or whatever else, or you've got additional questions, can you please make comments at some point? Because it will help me, it will help SRUK, and it will therefore help others in the future. So I sincerely hope you have found this helpful, and I hope you have an enjoyable day, wherever you are in the UK or elsewhere. Thank you.